Welcome to the WPA section of Evolutionary Psychiatry webinar series. If you are interested in evolution and psychiatry, please consider subscribing to our YouTube channel, which is EPSIG UK. We are continuing with the theme of evolutionary perspectives on depression. We had our last lecture by James Turner. And it is my great pleasure to introduce today's speaker. Leif Edward Ottesen Kennair is a clinical psychologist and professor of personality psychology at the Norwegian University of Science and Technology. He's editor-in-chief of the Scandinavian Journal of Psychology and previously was head of department of psychology at his current university. Leif is a member of the Royal Norwegian Society of Sciences and Letters and was appointed to the Norwegian Cabinet Committee on Women's Health. He has a range of research interests that include the effective interventions for anxiety and depressive disorders, and also testing hypotheses in the field of evolutionary psychology. He applies sexual strategies theory to explore topics such as jealousy, regret, and harassment, mate preferences, and the use of dating apps. A topic which is close to Leif's heart is the mystery of the evolution of mental disorder. What a coincidence. That's also the thing closest to my heart. So Leif's title today is Sustained Negative Processing Adaptive? So welcome, Leif, and over to you.
Thank you very much. There we are. So thank you for having me. Today's talk will be largely a repeat for many of the people who went to Durham, but I think this might reach a large audience, so let's hope there's something new here for people too. So the topic today is how may we consider sadness and depression from an evolutionary perspective, but also the whole point from my perspective is that depression is maintained by rumination. So to what degree is the maintained negative processing adaptive? And I'm going to contrast this with fear and anxiety, which are one, fear is an adaptation that we know very well the function of, and anxiety disorders are disorders that we know well how to treat efficiently, much, I would say, due to how we understand the function of fear. And the overarching theme here is how can we improve evolutionary psychopathology's approach to studying mental disorders and especially depression. So just to give you the summary first so that we're all on board, I think we've overreached. We've tried to understand the evolution of depression, but we still don't really understand fully the function of low mood. And by primarily considering depression, we're implicitly or explicitly suggesting that the dysfunction has an adaptive function, which surely is a mistake. Also, it's a typical human metacognition to believe that sustained negative effect is helpful. The cognitive emotional processing involved in worry, rumination, self-processing, regret is all considered very helpful by people in general, but probably that is not true. Also, we understand the dysfunction of anxiety primarily because we understand the function of fear. And this helps us clinically because we know what to look for, we know what safety behaviors to address, we understand what feedback will recalibrate people's emotional responses. Therefore, we know how to treat fear-related disorders probably so much better than low mood or sadness-related disorder. Which brings me to the conclusion that if we understood sadness better, we might understand depression better. Alas, we really do not understand the function of sadness very well at all. So anxiety disorders are treated efficiently because we understand the function of fear. Several adaptive and evolutionary-based explanations for anxiety disorders have been proposed, and none of these have been very convincing. One of my favorite objections are the different theories that tell us how social anxiety is supposed to protect us against being ostracized, socially excluded. But one of the most typical consequences of social anxiety disorder is social self-exclusion. People with social anxiety disorder partake less in social activities, in social competition. They marry at a later rate. They have less romantic experiences. They are less socially active. So the idea that social anxiety should improve us and help us behave socially more apt is very unlikely to be true. Typically, people with lack of social anxiety, people with extroversion, get on like houses on fire in social situations, and most people actually are quite friendly. So fear of actual danger or threats is adaptive. Anxiety disorders in general are not. Here's one of my favorite examples, and I actually have done a bear phobia training course. It's quite interesting. Here we see a Norwegian brown bear ready to eat this poor person with his shopping. And that's fear. So we understand why he's being activated and is contemplating whether or not to play dead or become dead. Anxiety is very much similar to, not perfectly similar to, a fear response, but very much similar to, but it's in the absence of an actual danger. So this is the neurotic, the imagined thing that might kill you. And often the imagined thing is much more scary than the real thing. Specific anxiety disorders are understood and treated efficiently based upon a functional understanding of what one fears specifically, what non-necessary safety behaviors are activated by the over exaggerated fear response, how misattribution of these safety behaviors maintain the disorder, and how discontinuing safety behaviors and avoidance is helpful. This is the basis of efficient behavioral, cognitive behavioral, and metacognitive therapy, and is largely summarized in the exposure and response prevention model. Anxiety disorders are treated efficiently because we understand the function of fear. It tells us how panic, a fear of heart attack, choking, fainting, or going mad, which is the typical, none of this is going to happen. If it really did happen, it wouldn't be a problem for hospitals that about half of their patients being trying to get admittance to the heart department actually have panic disorders, panic attacks. You do not choke. There's one type of anxiety that might result in fainting, blood injection injury phobia. But apart from that, you've got an increased blood pressure, not a drop, which would be the necessity for fainting. Also, people do fear going mad when they're having panic attacks. That neither happens to any large degree. So panic is maintained because of the misinterpretation of the anxiety symptoms as one of these or several of these catastrophes. And it's then maintained by safety behaviors that are invented by the patient largely to try to prevent the catastrophe from happening. and therefore they do not understand or discover that the catastrophe isn't going to happen. So what one does in the treatment of panic disorder is discontinue these safety behaviors and change the perception of the anxiety symptoms as non-lethal threats. And in that framework, panic would be, in general, treated in about 5 to 8 sessions. GAD, generalized anxiety disorder, is an excessive worry disorder, and the fear that worry itself is both helpful and harmful and uncontrollable. So you've got both beliefs that it's helpful and that it's harmful. And worry itself is the safety behavior. And rather than, as one would in cognitive therapy, in the metacognitive therapy, one actually discontinues the safety behavior worry. And this is, to a large degree, what treats GAD efficiently. Social anxiety disorder, as mentioned, is a fear of being ostracized, fear of being found out as weak or anxious. And based upon an interception of symptoms, the patient gauges the severity of how odd they look, how anxious they look, how strange they look. And the safety behaviors will often involve social avoidance and attempts to conceal the different symptoms. So discontinuing these safety behaviors and providing feedback on the actual expression of anxiety symptoms is often enough to improve the patient significantly. Simple phobias, one of my favorite, is mainly about danger monitoring and avoidance. There are two emotions involved, both disgust and fear, and often these stimuli will be evolutionary relevant. However, recently on national television, I treated a celebrity's prawn phobia, where the phobia was connected to disgust of the slippery and slimy texture of the prawn. Exposure with response prevention is the efficient treatment for phobias, and probably nothing more than that is really necessary. I think across the last 25 years, we've got about 100% improvement across all cases. Nessie, in his wonderful book, warns, viewing diseases as adaptations is the most common and most serious mistake in evolutionary medicine. Diseases themselves do not have evolutionary explanations. They're not adaptations shaped by natural selection. The correct question is, why did natural selection shape traits that make us vulnerable to disease? I just have to turn right back. So the point here is simply, if we start considering that the dysfunction is itself the adaptation, that is a misunderstanding which will probably lead us down the wrong path. However, one of the most popular evolutionary approaches to depression is the adaptive rumination hypothesis. This suggests an adaptive function for depressive symptoms and rumination, and the more complex problem demands a larger dose of rumination. Anhedonia, sleep problems, reduced behaviors all exist to improve problem solving, free up time to ruminate. And discontinuation of rumination will exacerbate social problems over time, while increasing rumination is hypothesized to improve depression over time. So depression is considered adaptive, and most evolutionary-oriented clinicians are slightly skeptical of this. Increasing rumination, prolonging depression is a highly ethically questionable practice. Any interventions that prolong depression increases the chronification, increases the different side effects and sequelae involved with prolonged depression. Also, the tenets of the adaptive rumination hypothesis overlap substantially with the metacognitions that we intervene to change in metacognitive therapy. Actually, the tenets of the adaptive rumination hypothesis is, to a large degree, what one is targeting for change in the metacognitive therapy of depression. Some evidence of the model. This is from a large sample, 1,200 adolescents from my part of Norway, where we consider how the most important pathway here is how negative metacognitions, primarily beliefs that one can't stop brooding being the dark and negative aspect of rumination, and depressive symptoms measured with the full BDI. And as you see there's a pathway directly to non-control of brooding, in addition to the strong pathway to the brooding, and from brooding to depressive symptoms. So people in a normal sample will have enough variance in depressive symptoms, brooding, and negative metacognitions that in normal community population, we can see how this model holds up. We've run a few trials with this treatment for patients, and our first publication in 2018 suggested that across 10 sessions, MCT would be a promising treatment with an extremely large effect size, both for depressive symptoms and anxiety symptoms. We also considered the effect after a year, and as you can see, the effect sizes for depressive symptoms and anxiety held up across the year. So the conclusion was it's a relatively stable treatment effect at 1 year follow-up. But depression, if you want to have an efficient treatment for depression, it's something that has to have a more lasting effect, because relapse is typical, and people usually don't measure relapse between post-treatment and follow-up. They just measure the point relapse at follow-up. So we considered across 3 years, and still we saw that there was an effect. Several of the patients had relapse episodes, but the whole point of an effective treatment for depression is to reduce number of relapse episodes, have less severe episodes, and shorter length of episodes. So at 3 years follow-up, 60% of our participants had not had new episodes, clear reduction of depressive symptoms, anxiety, worry, interpersonal problems, and metacognitions. Only 3 of 34 fulfilled the diagnostic criteria at that point, 1 for depressive disorder and 2 for generalized anxiety. Only 11 to 15 had ongoing relapse at follow-up, and 70 had experienced negative life events, but these were unrelated to current level of depression. So there was clear improvement across several different criteria. Also, the average quality of life was improved, and also their function. While before treatment, 12 were working full-time, 8 were studying, 6 were studying part-time or working part-time, 13 were unemployed or receiving benefits. At 3 years follow-up, 26 were working full-time, 8 studying, and only 5 of the patients were receiving benefits. So reducing rumination results in good and lasting improvement across an unusually long follow-up period, including more functional behavior and improved quality of life. Worry and JD share most of the genes, and there's also 50% comorbidity. So one of the interesting aspects there is that one finds that worry is apprehension about future events. Rumination, brooding, is largely a focusing on everything that's gone bad in the past. So largely it's the same kind of mental processing. It's more about the time aspect. Are you considering the future or your past? Discontinuing worry and reducing metacognitions provided better effect than challenging worry content and training relaxation, as in the Borkovic model. And in this specific paper, we had effects lasting 9 years, where the differences between the metacognitive model and the cognitive model actually became larger. So over time, metacognitive therapy actually had a greater effect. This is extremely long term. 9 years is probably unheard of. And rather than boast about it, I'll just admit that really it was because it took us a long time to get around to doing it. One of the fascinating things from a psychotherapy and history of psychotherapy perspective is that in the good old days, we treated personality, not symptoms and states, while in current thinking, most of our psychopathology that we treat is mostly mental disorder states. So this research combines some very odd perspectives because some of us believe in trait models of personality and inefficient treatment of mental disorder. So we used the NeoPi full questionnaire to assess the patients before they received their treatment for GAD and after. And what we actually see is a fascinating normalization of personality. Where neuroticism falls, the neuroticism scores fell actually as much as the symptom measures of anxiety and depression, while extroversion and openness increased and normalized. And the profile of neuroticism, extroversion, and openness is typical for GAD patients. So reduced extroversion and openness, heightened neuroticism. So this shows that efficient treatment also normalizes the mentally disturbed personality too. In addition to rumination and worry, we've got several different ongoing processing of negative content that we actually believe is helpful to us. And when you ask researchers or even the public, which of all of your negative emotions is your favorite? The most popular negative emotion is regret. People really do believe that regret helps them. It makes us make better future decisions if we've made some awful ones. It helps us behave better. The fascinating thing about this is that this is just a cultural belief that people don't really feel the need to study in any critical way at all. And we'd been doing quite a few studies together with David Buss on short-term sex regret. And this is one of the things where there's actually a sex difference. Men regret passing up chances to have short-term sex. They might be exaggerating the chances. Women regret having had short-term sex. And what we found was that sexual strategies theory predicts these differences. There's no problem there. But then we kept writing in our papers that regret will improve your future choices. And in 2021, we decided maybe we ought to check and see if this is actually true. Checking over a 4-month period, which is about the time it takes for Norwegian students to have a new sexual encounter, we found no measurable effect of regret on short-term sexual action or inaction. So there was no effect of their regret on their behavior. Regretting one-night stands did not result in choosing more attractive partners. It did not result in having fewer one-night stands or even entering into a long-term relationship. Actually, more regret reduced likelihood of the latter. Regretting passing up a chance did not result in a greater chance of saying yes the next time either. Also, I think most of us have to agree that we regret our bad habits, yet lifestyle illnesses are real, and from a Catholic perspective, most repenting sinners do not become saints. Still, we bother ourselves with regret, and most people spend a lot of time regretting stuff and second guessing their choices in life. Some of them trouble people quite a lot. Our next clinical project is going to be looking at metacognitive therapy for low self-esteem. People do a lot of negative forms of self-processing, comparing oneself with others, trying to check how one holds up against different ideals one has. And a lot of the worry about one's self-worth, a lot of the rumination about one's self-worth, and a lot of the negative forms of self-processing have a tendency to reduce one's self-esteem. So what we are going to do is attempt to discontinue the worry, rumination, and negative forms of self-processing, change the positive metacognitions about the helpfulness of such processing, and change the negative metacognitions about how it's not possible to stop such processing. Now, most of you stop yourself from this processing several times a day, even if you have a tendency to neurotically bother yourself with a lot of negative processing. You stop it when you start driving your car, you stop it when you answer the phone, you stop it when you turn on the television, and most people just stop it when they've had enough of it. Most patients, though, they start devising unhelpful ways of how to stop it, and therefore conclude that they have not control over these thoughts, and conclude, therefore, that it's impossible to stop. So most people who don't have a disorder just stop. Most people who have a disorder have started doing things like trying to distract themselves or trying to force the thoughts out of their head or suppress their thoughts. And anyone who wants to think about a white rabbit can now just try to stop thinking about a white rabbit. I guess that made a lot of rodents appear in the audience. Pilot data suggests that reducing these processes improves self-esteem scores. People believe that their worry, regret, self-processing, and rumination is helpful, even after they escalate to the point of bona fide mental disorder or just extreme mental bother. They believe that these negative emotional cognitive processes are adaptive or helpful. However, the evidence of objective positive effects is scarce, and there is evidence of the opposite. However, there's very little follow-up data to address these things in general, apart from the patient data that I've already told you about. Evolutionary-oriented researchers need to test claims to avoid pan-adaptationism. And one of the things that I fear about what we're doing in a lot of the adaptive approaches to mental disorder is not address this with what shall we say, the wondrous, testable, adaptive hypothesis, as maybe John Tooby would have put it. But what we're really doing is just following a sort of in-group shibboleth where we say, oh, it's adaptive, and therefore we do believe that it has to be true. I think it's a lot of in-group processing going on in how we address these aspects of our own pan-adaptationism towards mental disorders. And we should especially be cautious about proposing adaptive functions for dysfunctions, as Randy Nesse has taught us. Mechanisms regulating negative mood are vulnerable to failure for several reasons. And several mental disorders and common mental troubles involve persistent aversive emotional activation. And I think one of the vulnerabilities that we have is that we have a tendency to believe that when we've got a negative mood, the thoughts that we have, the emotions that we have, the experience that we have are a lot more, what should I say, serious, important, pressing, and relevant. On the other hand, I think a good life, to a large degree, it appears when we're in flow and when we're having fun and everything is a little more light and happy. That just might be my extroversion and my lack of neuroticism. One of the most recent reviews of current understandings of sadness is Forgus in the Oxford Handbook of Evolution and the Emotions, which was recently published. A large set of studies by Dr. Forgus and his colleagues suggest that induced sadness improves cognitive social functioning across a long range of different phenomena. Memory, performance, inference, judgment, social perception, interpersonal communication, deception detection, strategic communication, and interaction. Mild sadness is typically an effective response that occurs in problematic, difficult, and unfamiliar situations, and by triggering more cautious, pessimistic, and attentive reactions, it promotes a more appropriate response. Now, I don't know, but from my perspective, both my personal perspective, but also as a clinician, that doesn't really capture the quality of sadness as I consider sadness. And I find it a little odd that this is the best we can do on sadness. Just to show one example, and this might also be highlighting that I find it a little odd from an openness perspective to suggest that expressionist paintings are bullshit. Also, I think it's part of the human nature to be able to actually see meaning where there is no meaning, or to infer symbolic understandings and content in more vague or abstract expressions. And surely, if one had found the opposite, that depressives or people with sadness or low mood actually found more meaning in the abstract expressionist paintings, that would still fit the theory. And I don't really think that in any way this is fundamental to what is important in our understanding of low mood or sadness in any case. So I fear that maybe what one's studying now is largely the epiphenomena of mood induction on cognition, without that being exactly what the low mood is all about. Unlike the direct motivations and functional behaviors of fear, danger avoidance, defense, which we've studied in all kinds of species, and we've seen how all kinds of species will have species-specific defense responses and ways to avoid danger or camouflage themselves from danger, fly up, freeze, or so on. Or disgust, which largely is contamination avoidance, or jealousy, which largely is about mate guarding. The proposed functions of sadness are more indirect cognitive social processes, and as I said, more likely epiphenomena of the different processes that's been studied so far. The proposed adaptive effects of sadness could well be measured in many different emotional states, and are maybe more byproducts or associated features rather than the function. Also, there is very little or even none of no longitudinal evidence of these observed benefits. Also, from a more general perspective, we have ideas of what happens to people with hyperphobia. They die, or analgesia, again, they die. we don't have much information about the effects of reduced sadness. And I think it would be odd to me if their shopping behavior, the likelihood of being tricked uh, by con men, or not understanding, or maybe not enjoying art, would have been the major effects there. I think we need to get to the concrete function of sadness. In general, excessive sadness is detrimental in life. Excessive sadness is also often described as depression, but that's not necessarily perfectly overlapping. Low neuroticism and high extroversion are associated with less sadness and greater social thriving. People in general want less neurotic partners. That's the paper we're working on now currently. The inability to feel sadness intuitively not something we would recommend or wish to experience. The emotional numbing of that would be more typically of depression, but I think people, if they lost a partner, if they lost their job, I don't think they'd want to not feel anything, although some patients do say they'd rather not feel the negative effect. Contextually induced sad state is considered appropriate. If we do have a loss, we do feel sadness. But what are the outcomes for people with too low sadness, not mania, but lack of sadness over time? I think that's one of the interesting things we want to study. People with lower sadness, do they actually show some kind of lack of functioning? So, what we're planning to do in our research group here in Norway is to consider the fundamental aspects of sadness, the underlying mechanisms, the general function and specific functions of sadness types. Are there any subtypes? This looks to some degree a lot like a paper that Randy had a few years back. But also, we want to look at different types of sadness, like love, sickness, and heartbreak, and other normal sadness and grief patterns. What do people feel? What people do? What do people experience in different types and subtypes of sadness? And what are the processes, metacognitions, desire thinking, for example, involved in love sickness? And unlike fear, which is preventive, sadness is a reaction to something that already has occurred. And we have many different ideas, and very many of our colleagues have suggested different functions here. Is it reparative? Is it a detachment? Is it to secure support? Is it relational? Does it regulate emotions? And also, I think considering the underlying mechanisms that might be involved in pathological sadness rather than the disorder itself, this might provide us with the basis of understanding the evolutionary psychopathology of depression. One of the things about the evolutionary approach to mental disorder that I think is important to consider is that, to a large degree, many of the treatments that we have in mental health care today do not really appreciate the social aspect of mental disorder fully. A lot of the treatments don't consider relational aspects. Most of the treatments are very one person founded. It's odd how the social and status aspects of mental disorder are lacking from most psychotherapy theories. And while we do have some very good community-based, status-based approaches to schizophrenia treatment now, from an outreach perspective and from a from a status and coherence perspective, these are not very typical in most approaches, psychotherapy approaches to mental disorder. Some theories consider mother-child relationships, but they also probably overemphasize specifically these. Also, I think the functional approach is extremely important. I think most anxiety therapists have a functional approach. However, it's fear that's the function. and the disorder is a maladaptive fear-like response. I think having a more functional approach to depression, understanding how sadness and low mood might be working, might improve us there too. The large evolutionary approach to our psychology has just about gotten started. It's a very new science still, and there are a lot of specific adaptations that haven't been mapped, a lot of human nature that we haven't addressed yet. So we both have the problem of not knowing exactly how specific mental mechanisms are supposed to be functioning, and we neither have a perfect description of what happens when they stop functioning. So Wakefield's harmful dysfunction approach has the problem of us not really being able to specify the dysfunction. And one of the emotions that is functionally underspecified is sadness. Also, we need to be able to say what is functioning and what isn't functioning. And it's important to note that while sadness might be adaptive, depression still might not be adaptive. Also, the two are not absolutely the same. While everybody has a tendency for sadness, many people will not have a tendency towards depression to any large degree. Sustained worry is dysfunctional despite fear being adaptive, and also despite being able to plan for contingency being adaptive. I'm just back from Thailand. There were a lot of signs telling me where the nearest tsunami shelter was. If I'd left Norway with a map of all of the tsunami shelters, I don't think I would have enjoyed my holiday as much. And I think when people try to solve their problems through worry, what they do is they stop acting and they end up trying to solve a problem in their imagination, trying to solve imagined dangers rather than solving concrete problems. And I think getting around the question of how worry just is so totally dysfunctional and fear is still adaptive tells us how a lot of these ideas about how depression might be adaptive is jumping the gun. We really have to start off by saying that we need to understand the function of sadness itself and emotion, low mood itself, and how these building blocks that might or might not be functioning well underlie the emergence of more long-term low mood disorder. Evolutionary psychopathology needs more theoretical work. In most of my evolutionary science, I use theories that provide me with testable hypotheses, and almost every day I use sexual strategies theory to address specific questions, which to a large degree lines up a set of hypotheses that are testable even for entirely new problems like dating apps. It's not just psychopathology that has this problem, though. Most of our individual differences areas in evolutionary psychology suffers from the same. So personality development and psychopathology all have too much theory and too little evidence. Also, for many years, we've had the promise of improved therapy from an evolutionary approach, and it keeps evading us. I think I would like more of my colleagues in evolution psychopathology to understanding the most efficient treatments better. I think also that we need to stop addressing specific disorders as functional. More interest in efficient modern psychosocial interventions would also help us better understand symptom maintaining mechanisms and develop the evolutionary theory around why there are underlying mechanisms that might be malfunctioning, might be mismatched, might be receiving the wrong input. Alas, very few psychotherapy-oriented researchers within evolutionary psychopathology. Also, a better understanding of the underlying mechanisms, adaptive function, would probably be a more fruitful approach. So that is what I've been repeating a few times now, I think. If we could move from looking at the disorder to the underlying maintaining mechanisms, I think that would improve our theorizing. And I think we need to have that information specifically about the disorder, the natural, normal, adaptive sadness, and understand what happens when we have too low sadness and what happens when we have too much sadness, and what is the function of sadness in itself. I think that was exactly 3/4 of an hour. And I'll stop there with thanks to my co-authors, colleagues, and students.
Thank you very much indeed, Leif. That was a really excellent exposition of the position that you started with your title, and that is what I expected, and it is actually almost diametrically opposed to what we heard in our previous presentation in this webinar series. So I am looking for any raised hands. I can't see any raised hand at the moment, but I'm sure there will be. So I will kick off. Can I suggest to you that, I mean, you quite rightly raised the question in great depth of the function of sadness, and this is an urgent need, and really it is a very evolutionary question that I don't think that our colleagues in mainstream psychiatry bother themselves that much with. But isn't hypomania and mania a good prototype for the consequences of the inability to feel sadness?
Well, that's why I said I don't mean mania, I mean just lack of sadness. Because I think mania is something else than lack of sadness. I think it's an overexcitation of several different perceptual, experiential, phenomenological pathways. So I think you'll have a heightened excitability of all of these different areas, sex drive and so on. And I don't think that's a lack of sadness. I think that is something else. So
Well, I mean, I didn't mean to suggest that the lack of sadness and mania on hypomania, maybe hypomania may be more sort of relevant here than frank mania. But what I meant is the inability to experience sadness, because typically
yeah,
hypomanics and manics do not experience negative emotions when they experience setbacks. That is one of the characteristics.
yeah,
So they experience rebuffs, setbacks, failures, and they just brush them off. They do not. It does not affect them.
at
And
least
that's what I
not
meant,
while
really.
exactly, especially not while they're in that state. So what I'm really thinking of are people who don't have hypomanic episodes, but still have extremely low sadness scores across their life. Because if sadness is doing something specific for us, it would be super interesting to see what happens. What happens if you just don't have sadness? So if you don't have pain sensation, you don't know that you're burning your hand before you think, I'm not frying bacon now, and then you move it off the stove. If you don't if you're hyperphobic, one of my favorite words, you're going to die. You're not going to be taking care of yourself. And we know what the functions of pain and fear are. So say that you don't have manic or hypomanic episodes, but you still have very low likelihood of having sadness across all of those contexts where most people would be experiencing it. What are the consequences of that? That's one of the questions I want to answer.
Okay. Thanks for that, Leif. We have now 3 hands, so we'll take them in turn. Adam, then Evgeny, and then Randy.
Thank you, Riyadh, and thank you, Leif, for a very interesting presentation. So I'm very sympathetic with your view on potentially being this function of sadness, and the depression is sort of an overactivation of sadness. And so you point out that we haven't tested these hypotheses. I do think that one of the problems with evolutionary psychiatry, in comparison to evolutionary psychology, is that it's very plausible that many of these emotions or reactions or even just stable personality traits are no longer adaptive in weird societies. So maybe sadness is just kind of bad now, or maybe even moderate levels of anxiety, because we've created a world that's so safe and comfortable and you really actually don't need to be afraid at all. Maybe even many positive emotions are kind of dysfunctional in some way, and we should be kind of rational Homo economicus. Which I think evolutionary psychology can kind of say, well, okay, love and jealousy, these are things which you can still see. You gain a relationship. We can make a good argument that that's an adaptive strategy. So I'm wondering what you think these experiments could look like to find out what the function of sadness is. If the function is no longer there, how are we going to find it? And does this mean that we should look outside kind of weird societies? Yeah, these are the things I'm thinking about.
Well, just crossing the road, I need some fear. I mean, doing my tax returns, I mean, there's some ability to mentally time travel even in our safe and regulated societies, that I think we need to consider most of these emotions to be rather intrinsic in everyday functioning. Therefore, therefore, my question, what would we expect from a person who lives their life but doesn't have sadness? Will they have two fleeting relationships to be able to attach? Will they have an inability to take care of their status, their jobs? What is typical of them? Would we find that they overlap so much with psychopathy that it's really just a lack of a, like a social aspect of it's like a form of color blindness? I mean, there's some. I think there's going to be in that negative of the negative image of a lot of neuroticism and a lot of sadness. I think we might be able to detect even in our societies aspects of function.
Yes.
Great. Maybe not to the
Next,
same extent is my only comment. Sorry. But yes, go on.
Yeah.
Please.
Next questioner, Evgeny, please unmute yourself and go ahead.
Yeah. Thank you, Leif, for this presentation. So I'm a Russian doctor transplanted to Glasgow and currently in training in one of the hospitals there. I grew up in Russia and spent a lot of time where I saw only one patient with clinical depression. So for me, it was a cultural shock in the UK where every fourth, fifth person got a depression. And I was looking at, and for me, it was like clear sort of picture that people have explanation for that. And I was thinking all the time that it's normal to feel like that if something bad happened to you. It's not obvious, but I've never saw something which comes from nowhere. And then I was contemplating then when I feel sad in a similar situations. And also funny, if I'm listening to sad like slow part of Tchaikovsky or whatever, I also feel sadness, but it's sort of pleasant sadness. Don't know. And I want to ask you a question, by the way. This studies you've done, because all the time I'm curious myself with the patients. I'm trying to find out what actually is standing behind this emotion. What thoughts about yourself? In our balance group, I'm saying I'm always curious about self-esteem because I believe that clinical depression, schizophrenia even, quite often it starts from low self-esteem at some point. And uh, is there a sort of cultural element between, we can say, these reactions, adaptation reactions or whatever, between male and female, between boys and girls? Because you can see that sort of potentially the ladies are more prone to this sort of brooding and ruminations, and men go for other stuff. I don't know, fighting with somebody, define rules of society, antisocial behavior, alcohol, drugs. So is it a cultural thing which is imposed on both sexes, or is it something which is now, I don't know, genes, evolution? That's the question.
There were a lot of questions there, but just to address the latter, in the adolescent data that I showed, the girls are higher in all of the specifics. So they brood more, they've got more negative metacognitions, they've got more depressive symptoms. And the boys and the girls are in the ages 16 to 19, they have no change, while the boys are lower but are rising across those ages. So it seems that once one gets into puberty, there is a sex difference that emerges, and that stays with the sexes at least through adult years, and then I'm uncertain what the development is in older age. But the boys never catch fully up in the ability to be neurotic with the girls. So if that's your question, those data seem to be typical in general around the globe. And then you asked if there was a cultural aspect. Well, yes, there are cultural aspects to how allowed you are to show different expressions. Most cultures will recognize sadness faces from other cultures, but in most cultures, there are patterns of acceptable behaviors for expressing emotions. So what is allowed for some groups of men when in some cultures will not be allowed for other groups of men in other cultures. But as you know, even smiling is different in Glasgow and in Russia. If you want to come across as an idiot in Russia, you smile a lot. If you want to come across as friendly in Britain, you try to be humorous and smile. So I think showing intelligence through humor in Glasgow and not smiling too much in Russia is an expression of how to fit in and be socially adequate. You have to know the cultural expressions too. So I think that's just typical for all evolutionary psychology. We know there are cultural aspects. There will be sex differences. There will be fundamental universals. So every aspect and every question we address, we have to have those different levels of analysis. Did that answer your question?
Yeah, thank you.
Okay.
Thank you, Leif. Randy, unmute yourself and go ahead, please.
Thank you. So a comment first is just that I think this is the way we should be doing evolutionary psychiatry, and the balance that you show and actually doing extensive projects with data. I mean, how wonderful. Also, you challenge one of my core beliefs, Leif. I've always said that what kind of treatment doesn't matter nearly as much as the relationship with the therapist. And maybe you just have a really good relationship with patients, and it's not just so that's one question is how much do you think of your response is specific to this? All the data shows that it's therapist, not kind of treatment. But my more interesting question is probably about whether you think that sadness and low mood are basically the same thing. I've argued that low mood has to do with ongoing pursuit of goals, and sadness has to do with a specific loss. And we should talk sometime about a 3-year project I did to answer the question about sadness using a very large prospective database about grief. And as you may know, at the end of that 3-year project, I decided that I didn't know the answer. It was very frustrating to not get an answer.
Exactly. And I absolutely am going to have to bother you at some point and have to discuss these things in much detail. Let's start off with what was the first one? Yeah.
First one is just if it's a relationship.
How well do you know Bruce Wampold?
Not well.
No. So he's got the Dodo experiment conclusion paper from 97. Where he concluded all are winners and all need prizes, meaning there's no differences. Problem of that research was that almost all of the research at the time that one could use to make those conclusions was from the behavioral cognitive set. So one was looking for variance within one set of treatments. And then Lambert sat in his rocking chair and suggested that these are the numbers of explained variance as a result of mental disorder treatment. But I was in a discussion with Bruce Wampold a few years ago, presenting these numbers, and I put it to him, given the fact that he has built his career on there not being differences between treatments, and I asked him the simple question, so either we're super therapists, or there is an effect of this treatment. And he was willing to give me the title super therapist rather than swallow his. I think to be honest, I've treated depression with many different models throughout my career. I've been a protocol therapist in different trials, and at least I think for me, there is no question about the CBT model being inferior to the MCT model for depression. But for anxiety disorders, this is just common knowledge. There is nothing that will beat response prevention and exposure for phobias or OCD behaviors. We don't really need more. That's what we need. Then for the panic and for social anxiety disorder, we need to add the cognitive, the mentalist level of analysis. And for depression and generalized anxiety, then I go on to the metacognitive model. And I think having different tools in our toolbox make us more efficient. So I'm probably not eclectic, but at least I use quite a lot of specific models to treat specific disorders. And I think that's why I want us to notice the fact that while it's in vogue currently to be critical of diagnosis in mental health care, especially the anxiety disorders are exceptionally well defined. And knowing the specific treatments based to address the specific safety behaviors and cognitions involved and processes involved improve our ability to treat them immensely. So I want people to be, I really want people to start learning specific models based upon the knowledge that we have, rather than suggesting that it's a one. And also, love is not enough. So a good relationship to the therapist, there is something narcissistic about believing that all they needed was that one relationship to me, and that would help them. I think we need to do something. Once we've got a good relationship with the patient, a working relationship, bought in, then we need to thereafter do something efficient.
Thanks.
Yeah.
We need to move on, I know, but wonderful response.
Thank you very much, Leif. And Costa, unmute yourself and go ahead. We can't see you, but we can see you now. Go ahead.
I should say, Riyad, I think there's a question in the chat that was prior to my raised hand. So
I will deal with that. Don't worry about it. I will make sure that question is dealt with.
Thank you, Riyad. And Prof, thanks again for a really wonderful talk. Could I possibly switch gears and talk a bit about theorizing and asking you a question about the functional decomposition of traits and symptoms and disorders? And this is something that I've been thinking about a lot, but it'd be really good to get your thoughts on this. Take a concept like bipolar disorder. I think we'd all agree that's not the right functional level to think about evolutionary explanations, but you can decompose it into traits. So depressive episodes, manic episodes, phase switching, and so on. And you could look at that level, but you could argue that's not the right level either. You must decompose it further. So you take a mania, but the question I've got for you is, how do you know what the appropriate level is to focus on? Because say it's not the mania, say it's the grandiosity. Is that the right level? Or is it the high self-esteem? Is that the right level? Or is it a combination of them? Is it a cluster? How do you think about this in your theorizing?
Yeah. So a few years ago, Lukashevsky et al. Published a paper on personality, which was super interesting. I found one, I get frustrated when they can't learn the behavioral genetics, but because the mechanism that creates the differentiation is a problem. But what they did, which I thought was impressive, was just highlighting traits aren't things. Personality traits are not the thing itself. You can't reify the description level. And that's I think what you're addressing now. What is the description level? What is our diagnosis? What's the name we've given it? What are the traits we're looking at that we can describe something by? What are the underlying mechanisms? And I think these network analysis are moving us one step further towards understanding how the interplay of multiple aspects of mental disorder across the board. I mean, we've got the genetics, which is overlapping for very many of the disorders. We have a general pathology factor, a P factor, which is genetic, but we've also got networks of specific symptoms which overlap between the different disorders and are both related genetically and related to each other in different packages and strengths. Now, they are still at the descriptive level there. So what I would advise is much the same as Lukashevsky et al. Do, going to look for what are the specific features and adaptations that must be underlying, say, a trait like agreeableness, and they look at aggression or mechanisms that increase the opposite of agreeableness. And I think in mania, you'd have to look at things like emotion regulation, but also I think general patterns of neural excitability, not emotional excitability. But so it seems that certain pathways involved in both sexual, perceptive, other processes are highly excited. And what is upregulating that? And look at all these different little pieces of, what shall one say, mechanistic hardware that must be underlying the output of what we're observing and describing at the description level. So I think a lot of our science really has to get in touch with the mental mechanisms involved in, and that means that we need to know something about, we need to know more about how emotion and perception interact. We need to know more about what regulates libido in general. So there's so many different aspects involved there. Why are the brakes off in mania? What are the brakes that aren't working? So I think your perspective is absolutely spot on. We need a lot more detailed level mental mechanism approaches to what, and that's in general what I was trying to talk about. There's so many parts of human nature that we've just started describing. So we are still at the start of the project of trying to describe the underlying mechanisms that underlie the failures that we then try to treat with our interventions.
Thank you.
Thank you very much, Leif. I'll now deal with the question in the chat box. I believe the questioner has actually left because he had, they had to leave. But I will.
They're still here. They're still. It's Jay.
Are they still here? Okay, because I saw another entry saying, "I'm sorry, I had to leave."
No, different person.
Okay, different person. Right. So there is a questioner by the name of Jay, and his question or her question is: to what extent do you think it is valid to speak of all sadness as the same, regardless of the context in which it arises? Do you think we might lose some detail, stroke complexity in doing this? Could we speak of different types of sadness?
Yes.
Very good question.
Yes, and that follows up on some of what I did not answer when Randy asked his question. I think Randy is one of the people who's actually done some work on trying to differentiate between different types of sadness and low mood, and what behaviors and traits and experiences are involved in different types. And I think different types of sadness are familiar to us. We have grief, we have disappointment, we have love sickness and heartbreak, we have the melancholy that Evgeny was describing. That, I mean, he was listening to these Russian composers, but my generation, all of the girls were listening to Nick Cave and feeling very, very serious and in touch with the darkness of reality. And I think a lot of us enjoy, I don't, but a lot of people love this sort of dark and true, and this feeling of being in touch with the reality, which is harsh and bad. I'm too extrovert to get along with that, but I think we have many, many, many different aspects of sadness, and I want to have that as part of the focus of our future research, considering both the different situations that the different emotions are designed to help us cope with, but also the different mechanisms underlying the different aspects of these different emotional expressions, which we call sadness or low mood or whatever. And I think tidying up all of these different words and concepts is actually a process in itself.
So I mean, it seems that that question has a number of different strands to it. There is the issue of the different kinds of sadness, and there is also the different pathways that may lead to the same kind of sadness. And these different pathways may be revealing about the certain human species specific qualities, traits, and so forth, because there are certain life events or certain life situations that may lead to low mood, but that is because it is a human context where a different species or a different organism in a different context will not necessarily experience that that low mood. And that would be an argument for it being functional, wouldn't it?
Well, I mean, that's one of my points. It's what would happen if we didn't have sadness is one of the questions I think we have to. I mean, we have to answer the negative to
Yes.
consider the positive too. And I think all of these different aspects of, I mean, a network analysis approach would tell us something about which aspects of what behaviors. I mean, do you always seek the comfort of others? Do you always want to eat ice cream? I mean, there are so many different aspects of how people deal with and cope with sadness. Is it the social aspect, or is it the interpersonal aspect? Is it the intrapersonal aspect? I think there are several different forms of low mood, grief, sadness, melancholia, and so on and so on and so on. And I think we need to grapple with them and see which of them have which features and what is it that defines them. And I would really like to know what happens to a person who doesn't experience it, because that is, for me, one of the ways of identifying that it has a function. And whether Adam is right or not, that function would be clearer in a hunter-gatherer society than in a Western society, I don't know, because I think it's typically the emotions and things I'm working with, they seem to be rampant in our society, at least. The worried well. We're all doing very well, and we're all really neurotic about it.
Randy has just put a comment in the chat box, which is, I was surprised to find no big problem in people who do not experience grief.
I agree. That scares me a little, because I'm sure sadness has a function, and there should be some adjustment problems for people who aren't experiencing functional emotions. That's like, I mean, that's all. It's, how can one be a psychiatrist or psychologist and not believe in that?
Randy, you raised your hand.
Yes, I know we have to stop, so I didn't want to interrupt at all. But I mean, I spent 3 years doing the largest prospective study of bereavement ever done, specifically to answer this question, Leif, and I was astounded. But if you read the paper, you find out what I keep learning, and that is every individual is an individual, and trying to generalize completely about, grief. Well, it didn't work. It didn't work very well. Also, people turned out to say, I forgot. I mean, they didn't say it. But the data showed that they forgot that they had grief when, in fact, they had intense grief. So it's very hard to study. Wonderful question, though. This is a whole important avenue, and I hope you'll pursue it.
I really enjoy the way children grieve, the way they flip in and out of it. It's not a continuous maintained carpet of grief. Also, in some cultures, people are grieving, but they actually pay people to display their grief for them instead of displaying it themselves. And there's so much that suggests to me that forgetting that you really are grieving is both part of the grief and part of the healing process, which Randy also has written about. But I think one of these important aspects of grief is that in Western society, we almost feel ashamed if we don't have this carpet style grief where we get up in the morning and we grieve the whole day until we go to bed. And if we laugh or find any mirth in our sad situation, it sort of gets us all worked up. I think I actually made a point of it when my mum died a few years ago to try to grieve more like a kid and flip in and out of state rather than staying in it. And we actually went for vacation, me and the family, to Greece, and I had some very good days. And I felt the flip back and forth emotionally. And I think that was a good way of dealing with it for myself, but I don't know. I think kids grieve in a very adaptive way,
Is
where they
it
forget, where they actually forget the grief for smaller or longer periods of the day.
is it not one of the major issues in weird societies that the dominant norm is individualism, that individuals are have private emotions, and they deal with issues in private, in a private way, and so forth. Now, I would suggest that the default human species specific mode of experiencing emotions is a collectivist one.
Yeah.
And it is for immediate and public sharing, and not to suffer alone, individually, and being cut off from others. And I think this might be because, I mean, in hunter-gatherer settings, it was almost impossible for an individual to be on their own and suffering on their own and with their private thoughts and emotions for any length of time.
But you wouldn't even be grieving alone, because if someone died, it wasn't just your relation that died. It was a person that was in a relationship to multiple people of your group. So I think the fascinating thing in modern society, industrialized, detached, moved away from your group, found a new place to live, be it Glasgow or whatever, you're in a situation where you actually can be the only person who knew the person who's just deceased. But, oh, lights went again. Now, this wouldn't be possible. There we are. This wouldn't be possible in a hunter-gatherer group.
No.
You would never be the only person who knew the person who deceased.
No, and you wouldn't experience any kind of emotion or display any kind of emotion, whether it is positive or negative, without sharing it almost immediately with others.
Exactly. So, if anything, it's fascinating how many of these private emotions that are still important to us and that we carry on with on our own, and don't share, or if we share them, only share them with very few people and very closely. So it's fascinating how modern Western life actually does work.
Now, I can't see any more hands, and I can't see any other new entries in the chat. So this might be a time to wrap up. So thank you very much, Leif, for sharing your research and your thoughts with us. It's been fascinating. Can I just pop a question? If we were ever to set up a debate between two evolutionists, one on the one side that depression is functional, on the other side that depression is primarily or mostly dysfunctional, would you be game to take part in that?
Yeah, I guess that's my judo black belt diploma on the wall there.
No, this is a real proposal, Leif.
Yes,
but
I'm
I
always
might.
game. I'm always
Okay.
game.
Excellent. I might email you on that, and we might have a little chat on that. So thank you again, and thank you for the audience for their excellent questions. And good evening, everyone.
Thank you. Thank you.
Thank you all. See you around. I'll close the room now.
Thank you very much.